Welcome, Zing Fan. Welcome, Zing Fan.
Hi, nice to meet you.
Okay.
Okay.
Hi, you can hear me okay?
Okay.
Okay, are you Zing?
Yeah. Can I try to share my PowerPoint?
Yeah, you want to try it? You want to try it now?
Yeah.
Okay. We have
Okay, thank you.
time we have time. Okay.
Can you see my PowerPoint?
Yeah, make it presentation mode at the bottom. Yeah, perfect. You see it? Okay.
Oh, yes, thank you.
Yeah, it's perfect. The whole screen.
Okay.
So how are you? I'm
Thank you.
John Bennett.
Sorry. Okay. I can access.
Okay, I'm not sure.
Okay.
I'm not sure if you want first or second.
Maybe I'm the second.
I don't know. It's up to Juan Lee.
Oh, yes, thank you.
You know Juan Lee, right?
Maybe I am the second.
I don't know.
They told me before.
Okay. They run the show.
Thank you, thank you.
Okay.
Another.
The people wait to the last minute to come. Makes me very nervous.
There's no need for you to nervous.
Yeah, I don't know. But I've
We still
won,
have 10 minutes.
I have run many webcasts, thousands, but only one time did someone not come, one speaker not come. Only one time of all the time.
Okay, I didn't say another speaker. Oh, our chairman, yeah.
Okay, yeah, Medtion is here. You know Medtion, right?
Yeah, thank you.
Yeah, they are here. Hello, Andy Wang. I don't know if you want to say hi. I don't know if you can say hi. He's here now, televising it. It's a Medtion, which that gives me an idea. Maybe I'll just screen share it. Okay, here we are. Oh, boy. Yeah, I'm going to screen share that. And see, look at this. We all know that, right?
Well, I am the first. Sorry, I have left for a moment.
That's a live screen now of Medtion.
Yeah, but they told me I'm the second speaker.
No, this is no relation. This is the banner I made.
Oh yeah, I know.
I don't know how. Hmm.
新浪教授，那个主持人他在说那个直播的事情，对吧？
对。
对对，因为我英文不太好，对，就给他说呀，应该是我们这个，他说刚刚是什么意思？有说吗？
说我们不是，他就说那个我们到底是谁先开讲的问题。我说的是好像下午他们那个就是中华神院英文版告诉我，就是我应该是第二个，可能是那个另一位讲者先讲。
啊，好的好的。
哎，是这么个情况。
因为你刚开始他给我发了一个文字版的那个聊天，关于直播的。
是我刚才看他展示的那个界面，好像也显示的是我先讲，所以我就跟他就是提问了一下，就是说这个我记得他们给我安排的是第二个，然后他说这个没有直接的联系。
对，我看我这边日程也是神外资讯的，也是您第一个讲。
是吧？咱们那个神外资讯那边应该也是，就是应该也是日程都安排好了吧？就是应该是一致的吧？
对，是您第一个讲嘛，然后
不是啊，不是，他们下午告诉我是第二个呀。虽然我倒是无所谓。
刚刚那个他放出来那个应该也是您第一个。
是他放出来也是我第一个，所以我才问他这个问题。我说的就是他们告诉我是第二个，然后他说那个不一定是 就是不是必要联系的。
啊，其实也不影响，其实
啊，对对对，不是咱们这不是得谦虚一点，让人家先讲嘛，是吧？我估计可能是这个意思。
啊，
对，反正说主要是主持人安排顺序，这不知道他到时候具体怎么安排啊。这如
对我看
果如果要是安排是我先，那就我先。
啊，可以，应该是你先，因为那个日程是那样写的。
啊，那行吧，那是不是还得讲快点？咱们这个通常多长时间？
这个我看一下日程是安排多久的，1个小时。
日程我写的还蛮长的，但是他们跟我说的是按20分钟到30分钟准备。
那差不多应该是20分钟20到30分钟演讲嘛，然后半个小时他们讨论嘛，他们是这样的，他没有写那么细，就是说讨论多久，演讲多久，估计是1个小时您讲完以后他们会讨论的。
哦，是这个是大佬们讨论吗？我感觉这个
一起吧，应该也会跟你提问，我估计。
啊，这提问我感觉，哎呀，提问我还真不一定跟得上，实话是，因为我这个题还是比较偏门的，我操。
没事，到时候徐教授他们也会上的，应该都会一起讨论吧。
我知道，因为徐教授和袁立教授他们主持嘛，对吧？
对对对。再稍等一下吧，应该快了，他们还没上线。
是，哎，没事儿，这个咱们这大领导这个稍微晚点上线很正常。
啊。
嗯。
Okay, here's one lady.
Hi, John.
Hey, One Lee, how you doing?
Good. Yeah. Another nice weekend, huh?
Okay, let me get rid of this pen. Okay, did you have trouble getting in, One Lee?
No, that's okay.
Oh, okay, because Ben wrote me and said he's waiting, he's in. But I can't see.
I don't know. I just input the number. Maybe I can just tell him the Zoom number.
Yeah, I just emailed him the link.
Yeah, but it's more easy to log in Google Zoom with the number 841156835.
Okay.
Yeah, and then you just need to.
There's no hurry. There's no hurry.
Yeah,
just got here yet.
So we have Dr. Fan from Kentan Hospital as the speaker, and where's the other one? The Ip. Is he?
Zing is here. Zing is here.
Oh,
Yeah.
Oh, here's Ben.
Good. We have.
Hey, Ben.
Hello, John. Hi. Hello. Yanni.
Hi,
You
yeah.
had trouble. You had
Hi.
trouble getting in, Ben, or
Yeah,
Never mind.
I use the link, but I entered this in by your last mail.
okay.
Yeah.
Well, as long as you're here. Wan Lee's here and Zing is here. Ipe's on the way.
袁丽，今天第2个讲者是，
是那个尼泊尔的 Ip， 就是那 Ip。
我知道，另外中国讲者是
中国讲者是我们天团的范 Dr. 范鑫。
对，因为之前的那个他今天发的好像又错了，还是上一次的那个讲者徐。
哦，
他海报上面。
Okay, let me get another link for Ipe. I don't know what's going on. Ipe's having a hard time getting in too.
Maybe just tell Ip the Zoom number. So
Yeah, I'm gonna send him another link.
maybe we can start with Dr. Fan talk.
Yeah, I'm here. Professor John, Professor Xu.
Yeah.
Okay, I'm in contact with Ipe through WhatsApp. And he says he's having a hard time getting in, but he'll get in. So how are things in China?
Yeah, that's okay. China.
Lockdown. Okay.
Actually, no more lockdown. Yeah, but somewhere. Small area.
Oh, here's Ipe. Okay, good.
Yeah, I just sent the Zoom number to Ip.
There he is.
He also have the WeChat account.
So who will be the first speaker? I'm not sure about the sequence.
It's up to you guys. Good day, Ipe.
Hello, Ip.
Hi.
Long time no
Hi,
see.
hi.
Good to see you after a long time, man.
Yeah. Wonderful. Well,
Pinsu, good
Hi.
to see you. I hope
Good
to
to see
come.
you.
I hope to come to Shanghai in waiting for this, but I hope I get the visa. But now there are some visa restriction. I hope I get the visa.
now
Yeah.
almost the visa application is just back to normal. You can try if you want.
Okay.
You are
That
very
will be good. I hope in October it will be the same. So I hope to come.
for about 10 days.
Okay, great, very good.
Yeah, Ipe, a few years ago, we were in Nepal. And look
Yes,
where we are
yes.
now. Look where we are now.
John, I told you at that time that this thing would change the world. It did.
Yeah.
I'm very happy that it did.
Well, we did a lot.
Yes. I can see how great you're going right now. It's fantastic.
Latin America is really going well.
Africa too. So I see that now. Like for example, we were doing bypass, and then I was seeing Vin's video. So we were seeing, and then our concepts about the bypass, earlier concepts was probably a bit different. Now we have started doing it the way Vin does. It's much more easier, much more less.
Yes.
Okay, do you want to
Much more
start?
friendly.
You guys want to
Yes.
start?
Yes, we are ready.
Okay, Ben, I introduce you, right? Ben or Wan Lee, should I introduce you? Wan Lee, hello?
Yeah. Okay.
Should I introduce
We
Wan
can
Lee
begin.
first? Okay.
Yeah.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, One. Good morning from Miami Beach, home of Neurosurgical TV. I am honored with the presence of the Chinese Neurosurgical Journal. This is show number 7, I believe, Wan Lee, right? It's about 7 or 8. I think it's 7. Anyways, we're honored to have, we have Mike Cherian, who I started with doing this webcasting 60 years ago. And look where we are now in China. This is fantastic. So let me just turn this show over right now to Wan Lee to run the proceedings. Welcome, Wan Lee. Oh, I think
Yan Li.
his screen may be frozen.
Yeah.
Okay. Hello, Wan Lee, you there? I think it may be frozen. Okay, Dr. Bin, do you want to do the intro?
Yeah. So I think Yan Li have some difficulty in connecting. So let's welcome Professor Ip Cherian, my dear friend, to make the first presentation. Ip, please. Please unmute.
Thank you, Bin, and thank you, Yuan Li. I have very pleasant experiences of visiting China. I've been there many times, and you guys are truly skilled surgeons. So today I have with me my fellow from Italy, and whose friend was a fellow with Bin. So he is with us for skull base and vascular. So at his center, there's a lady neurosurgeon who performs bypasses. So he was telling me that. So
okay, is it Alicia?
Alice? Yeah. Yes.
Yeah. Okay.
So he's come to my center. It's a small world, you see. So today we wanted to show you about one of the tumors that we did maybe a month back. And this tumor was, I would share my screen first. I hope you are seeing this. Can you see this?
Yes, it's perfect.
Yes. So you will see this tumor, and somebody had done a biopsy, tried to do a retromastoid approach and a biopsy, but you can see that this is sponsed. And that is a basilar. So there was no way you could really do a biopsy. Even if you reached here, this part of the tumor would be completely inaccessible. So we wanted to plan something which wouldn't be so crazy. For example, a supracerebellar infratentorial will never do. Anterior transpetrous from this side also would be difficult in the way that these thin pons will have to be retracted a bit, and you see the basilar only at the tip. A transclival approach was planned, but the problem here would be after the bleeding basilar plexus is handled, you have the basilar, and of course the perforators are going to be there, and they're all going to be anterior to you. They're all going to be anterior to the tumor. You got to make the sectors between these basilar perforators, vertebrae, and of course the sixth nerve will be here coursing parallel, and so therefore it will be a bit difficult. So this was so we studied this tumor, and you can see the different configurations. And we were thinking what it is, probably is an epidermoid, maybe, but you can see the basilar is completely anterior to the tumor, and the tumor is almost reaching up to the fourth ventricle. It's a very bad idea to go from the fourth ventricle for this tumor, because it'll produce a lot of deficits. I'm sure you guys are experts in doing brainstem tumors, and a tumor like this, which is coming from anteriorly, taking it posteriorly, produces quite a lot of deficits. So when in many forums I was asked, why don't you go from posterior? I would say that's not the ideal thing to do. So you can see that the tumor is coming from anterior and burrowing into the brainstem. So it's completely within the pons. It's like the pons is made into a cup. And now you can see, this is what I want you to see. So you have pons all around, and that's a tumor. And the vessels are in front. The sixth nerve is coursing parallel to the clivus. And so you have sectors, you have basilar here, you have these perforators in front. It's exactly what you're going to see when you see this tumor being operated. So 13.5 centimeters was the depth of the tumors. So we had to, because post-operatively, when we're navigating, we need to kind of know how much depth we are at. So this is the 13.5 centimeter was the depth. And you can see the corresponding cuts here. So here my ENT colleague is using a robotic endoscopic holder, and he's operating. So we can see the typical anatomy now being made clear. So we went partial transmaxillary, and we defined all the LOCR, the lateral opticocarotid recess, the medial opticocarotid recess, the sella, the paraclival carotids, the paracellar carotids, and each one of them we defined it thoroughly. So in a surgery like this, it's very, very important that you define each of these landmarks. So we are preparing for a transclival approach, but if we need to, we have to do a pituitary transposition. So we have to drill the sella, take the suspensory ligaments of the pituitary, and of course, pull it up. And then, so now you can see the anatomy. So that's a paraclival carotid. The sella is exposed completely. That's other paraclival carotid. That is the clivus. We're drilling all the way down to the clivus. So that is what we are doing right now. So we need, and again, one more thing. This is the Gulfar segment of the cavernous sinus. So the tumor is here as well. So you need to expose this part. So this paraclival carotid takes a turn there. That's a C4 horizontal carotid, and then the C3. So this is the Gulfar segment where the basilar plexus, the inferior petrosal sinus, and the cavernous sinus comes together. And opening the Gulfar segment is a very bloody affair. So we opened it, but we could stop it with fibrin glue as well as some homemade preparation of gel foam powder. So the sella dura is also completely exposed and skeletonized. We don't need to go there, but once if we have to take the sella up, then because there is tumor in the interpetuncular system, so sometimes you need to go all the way. Now, another thing is when you open the clival dura, you have the basilar plexus and it bleeds a lot. So you have to completely skeletonize it. Not a single bone should be there. So now we have made a small opening, and then now we're going to take the dura up, because all the vessels, you will see now, when I go in, you will see that the vertebral is right there. So I made an opening right, and right to the dura, and I'm going to, the basilar plexus is bleeding. So I have to coagulate the basilar plexus up to the Gulfar segment of the cavernous sinus. So I am going in, and you will see right below my bipolar is the vertebra. So that's the vertebral artery. That's a vertebral. The basilar is here. So it's just like this. So this is, we have opened here, and these are the two paracellar carotids. So we have opened here. This is the sixth nerve. It will come like this. The sixth nerve will come like that. That's the basilar. These are the two vertebrals. the thing what they are not showing is this, the perforators are like that. So you have to take the tumor from between the sixth nerve, between the basilar, between the perforators. These perforators are vital. You cannot take them. So I'm just raising the dura up, the clival dura up, and I'm coagulating the clival dura. You can see the two vertebrals, and the basilar is on this side. And then you will see the sixth nerve on the surface. So that's the sixth nerve. That's the sixth nerve. That's a basilar. These are perforators. There's one perforator. We will show you the perforator after the surgery. So the whole point was dissect the tumor out. This was, fortunately for us, it was a soft tumor. So we dissected the tumor out. Once it comes to our level, you can suck it out between these two. I will show you the perforator right now. You can see that's the perforator, and that's joining the basilar there. So I am in the depth now. That is a perforator. So it's under very, very high magnification using that endoscope. That's a perforator, and it's joining the basilar there. And we are taking out tumor. So we went above, after opening the Gulfar segment, we went above. That's a basilar artery, that's a vertebral artery, and the tumor is being taken out till we completely saw the brainstem all around. So you can see you cannot obviously coagulate there. So you can see that the tumor, you could see the reconstruction, you can see that the tumor is completely out. We went around, and you can see this all bled around. So whatever seen portion of the tumor, we've taken it out. That's a fat graft there. And this is how she was post-op. I'd like to show you some of the things that we used during that surgery, which made things easier for us. Now, this is an endoscopic robotic holder. So earlier I used to have the Mitaka arm, the Japanese Mitaka arm, but the Japanese Mitaka arm, the disadvantage of that is that once you press the switch, press the release button, everything collapses onto you. And it's not very comfortable when you are operating with where you need a lot of finesse. It is not possible. So now this is a Franca Amica robotic arm with 7 degrees of freedom. And the beauty about this arm is that I designed it, and I made a company in India to do it for me. It's extremely safe. If it touches you, it stops. I mean, the advertisement shows that if it holds a pin and touches a balloon, it will not burst the balloon. That is the pressure sensitivity that it has. And it can be taught to come into the previous position. It's stereotactically, it can be positioned anywhere. Plus it's back drivable. I can just press this and keep it wherever I want. And it doesn't drop. Once I press the release switch, it stays there. There are torque motors, which is anti-gravity motors. So it stays there. So you will see how I can manipulate. This is the endoscope holder. So you can see how the endoscope is being held. This is the robot, and this is the endoscope holder. I can manipulate. I have also the NeuroPilot, Escolab NeuroPilot attached to the scope. So I can manipulate the scope in any way I want. So this is my ENT colleague Vinod Felix, very tall man. So it's easy for me to operate with him because I come only up to his neck. So this is the exoscope. This is an Escolab exoscope. This is, of course, not this surgery, but I just wanted to show you that what we use here. So this is the exoscope. It's another beautiful addition. I've completely shifted on to the exoscope. We have a Kinevo, but right now, at least for 2 months, I haven't used the Kinevo. I'm using only the exoscope. Even the anastomosis, we started doing it on the exoscope. It's a fantastic addition. I think this will be the future for sure. After we are trying to modify some things, but of course, I think this would be the future. So thank you very much. I'm looking forward for Yuan Lee talking right now. So I'll stop sharing my screen. If you have any comments, I'd be happy to answer.
Okay, thank you. So if please introduce yourself to the Chinese audience, because I know I'm not very familiar for your new hospital.
Yes, yes. So right now, I have come back to India. I was in Nepal for 14 years, and after that, I have come back to my native country, India. We have started building a neurosciences center, which should be ready by December. For last 1.5 years, we are building this center. It is for 220 beds for neurosurgery, 3 theaters and 220 beds for neurosurgery. It is very well equipped. We have a 192 slice intraoperative CT with virtual reality function, the exoscope, all of course the endoscope, navigation, microscope, everything. Maybe one of the best equipped centers on the planet. This is what our aim is. And we, of course, with ACNS, we wanted to be a training center for skull-based vascular. We have also colleagues doing spine. Of course, I don't do spine, but we have colleagues doing spine, and we want to collaborate, of course, with centers like yours. And we would like to invite you sometime over once the situation is better. I would like both of you, of course, definitely to come down and see this center. In Nepal, we really had a lot of limitations, but in India, of course, it is like China. We don't have much of limitations with respect to infrastructure. So, and plus this place is so beautiful. This place that I have settled down here, Western Maharashtra, is near the jungle. It's called Karad, and it's near the Sahyadri Wildlife Reserve. So it's really, really beautiful as well. So I'd like to invite all of you guys to come visit our center, teach, interact with us, and we can exchange ideas and go further forward.
Oh, great! So it's a pure neurological center, or
No,
not?
No. It's a 1,500 bed hospital, and it caters to every specialty. But my center, the Institute of Neuroscience, will have 220 beds only. I know
200 beds. So it's quite big. Okay.
Yes. It will be one of the largest in the private sector. It will be one of the largest in India.
Okay. Great. Thank you.
Mm-hmm. I'd like to show you who's watching in China, and Ben can probably. This is being televised also to medtion.com, and there's 15,000 people watching. Am I interpreting that correctly, Ben?
Mm-hmm.
Is that number?
Yes.
So there's quite an audience in China. It's 15,770.
This number is accumulated for the.
Oh, it's accumulated. Okay.
Yes. So almost 2,000 every time.
Okay. Very good.
2,000 to 3,000.
Great. Amazing. Truly amazing.
Yuanli, do you know it?
I thought my internet seems got some problem, but now it turned back to okay. Okay, so yeah. Okay, maybe we can move to next speaker. Thank you again. Hope to see you again in China or Nepal or India. Anyway, yeah.
Yeah, if you have time, you can stay and discuss with the next speaker. Yeah.
Yeah. Now we are building a new hospital in Kunming, Yunnan province. A little bit more short distance to Nepal.
Yes, I know. I have landed in many times. So to go to Nanjing, I used to come to Kunming first.
Ah, wonderful. Yeah. Okay. Okay. Thank you again. Bye-bye. Yeah. So let me introduce the next speaker, Dr. Fan from Beijing Tiantan Hospital. He's also a young neurosurgeon in our department. And so today, he will introduce some clinical experience about the epilepsy for the glioma patients, right? So please, Dr. Fan, are you?
Okay. Thank you for Professor Zhou's introduction. I will share my PowerPoint. Okay, can everyone see the slides?
Yes, it's okay. Yeah.
Honorable Professor Bennick, Honorable Professor Chen, Professor Zhao, and Professor Xu, and other distinguished guests and friends, good evening. It's my great honor to be here and share my topic, research progress in diagnosis and treatment of glioma-related epilepsy. As you see, I work
王教授打断，你没开摄像头。
Sorry.
Oh, I'm sorry.
I'm sorry. Wire to open.
It's okay. There's another
Okay.
audio open. It's okay now.
Okay. And as you see, I work at Beijing Neurosurgical Institute, and my major is intraoperative neuro monitoring, and also glioma-related epilepsy is one of my focus. First, I should provide a precise definition. Glioma-related epilepsy, GRE. It refers to epileptic seizures secondary to gliomas. It includes preoperative seizures presenting as the initial or prominent symptom, and new onset or recurrent seizures after surgery, and also intraoperative seizures induced by direct electrical stimulation, which was mainly occur in awake surgery for gliomas involving eloquent area. So here comes the question. Why is GRE worthy of our attention? First, GRE has a high incidence rate. For most glioma patients, particularly for those with low-grade gliomas, seizures present as an initial symptom for most patients and lead to tumor diagnosis, while some others may experience their first seizure later during the course of the disease. Second, GRE is generally hard to control. Most patients show drug resistance preoperatively, as tumor is the root cause, even after combining anti-tumor therapies with anti-seizure medications, of course, including surgical resection of the tumor. The seizure control is still unsatisfied. Third, most importantly, GRE carries both heavy financial and emotional burden on glioma patients and significantly decrease their life quality. This is mainly because epileptic seizures are arbitrary and unpredictable, which make the patients lose their independent living ability, and thus results in great mental pressure to them. Moreover, patients generally consider that seizures are closely related to the progression or recurrence of their tumors, which also adds to their anxiety. And this is a result from a Mayo Clinic study. This slide shows some classical epidemiological studies in this field. Under the guidance of our mentor, Professor Jiang Tao, our team is one of the early teams to pay attention to this disease around the world. And this study, which was published in 2012 by Yu Gan, showed our early achievements. To date, it has been cited a lot. Moreover, the latest one, which is also published by our team in Journal of Neurosurgery. It's the first study to comprehensively investigate the epidemiological characteristics of GRE in glioma patients under the 2016 WHO classification. Of course, as everyone knows, WHO classification had been updated again in last year, and we are preparing for the corresponding study now. Brain tumor is a major cause of epilepsy, and the epileptogenicity of tumor varies greatly with subtype and grade. Currently, two subtypes of tumor are generally considered as the most highly epileptogenic. One is neuroglial developmental tumor, like DNET. The other is glioma. And even in glioma patients, the clinical and epidemiological characteristics of GRE are also different according to tumor grade. In patients with diffuse low-grade gliomas, the incidence of GRE is about 65 to 90%, while in patients with high-grade gliomas, this number is 40% to 64%. As I just mentioned, we summarized the three possible rules to describe the incidence of GRE in different subtypes of gliomas under the 2016 WHO classification. First, the higher the tumor grade, the lower the incidence of GRE. Second, among tumors of the same grade, astrocytic tumors are less epileptogenic than tumors with oligodendroglial components. Third, among astrocytic tumors, including glioblastomas, those with wild-type IDH are less likely to induce GRE. Overall, compared with the 2007 WHO classification, the 2016 classification, which introduced molecular parameters in addition to histology, seems more conducive to reveal the distribution of GRE. As for the latest classification, the role of molecular parameters become more important. Maybe the new classification can be more suitable for describing GRE, which need further investigation. The inconsistency of serial characteristics between low and high-grade gliomas may be due to the difference in the mechanisms of epileptogenesis. The slow growth of low-grade tumors may result in the changes of peritumoral microenvironment, such as neurotransmitters, ion channels, and hypoxia, while high-grade tumors are usually considered to induce epilepsy through abrupt ways of tissue damage, such as mass effect, peritumoral ischemia, or hemorrhage. A mainstream view is that glioma and GRE may be comorbidity and share common pathogenic mechanisms. A typical example is IDH1 mutation, which is crucial for the integrated classification and clinical therapeutic decision-making of gliomas. IDH1 mutant glioma cells can release D2HG, and D2HG can promote gliomagenesis by affecting DNA methylation and cellular energy metabolism on one hand. On the other hand, it can contribute to epileptogenesis of GRE due to its similar structure to glutamate. For a long time, GRE has not received enough attention. Neurosurgeons and neuro-oncologists paid more attention to the prolongation of patients' survival rather than their life quality. And in 2017, the members from CAE, China Association Against Epilepsy, and SNO China, Society for Neuro-Oncology of China, started the project clinical practice guidelines for the diagnosis and treatment of adult diffuse glioma-related epilepsy. This work was published in 2019, and the relevant Chinese interpretation was published at the same year. This is the group photo of the expert panel for the guidelines. Most of them are well-known experts in relevant fields of our country. More importantly, this model of cooperation has also been continued. Recently, we finished another work on the application of anti-seizure medications in the preoperative period of neurosurgery. I hope I can share this work in the near future. The recommendation for the guidelines were also added to the 2022 edition of Clinical Guidelines for the Diagnosis and Treatment of Glioma, which was published by the National Health Commission. In the guidelines, we offered a preoperative diagnostic flowchart for GRE. It can be divided into 3 parts: diagnosis for glioma, for seizure, and to confirm the relationship between the two. If the localization of epileptic foci is inconsistent with that of the tumor, maybe the epilepsy and the tumor are two independent diseases rather than a comorbidity. This is one thing which needs to be noticed. This slide shows the recommended examinations for the diagnosis of GRE, which was provided only in the Chinese interpretation. MRI is essential to obtain a definite preoperative diagnosis of glioma, while video EEG is recommended for seizures. And since time is limited, I can't explain it in detail. Those interested can find it in the original paper. Treatment for GRE. The current optimal treatment for GRE is a combination of anti-tumor treatments and anti-seizure medications, ASMs. And the anti-tumor treatments include surgical resection, radiotherapy, and chemotherapy. One thing needs to be explained is that according to the recommendation of the renal group, here the renal means response assessment in neuro-oncology. According to their recommendation, radiotherapy and chemotherapy are both treatment modalities for GRE, not only for gliomas. Surgery up to now, the primary purpose of surgery for glioma patients has been tumor resection, but not seizure control. However, neurosurgeons have realized the importance of seizure control in recent decades and regard it as a second goal of surgery. It's generally accepted that gross total resection is better than subtotal resection. And in 2018, our team performed a meta-analysis and obtained the most effective data. And in 2019, Journal of Neurosurgery published a study. The study shows that supratotal resection can achieve better seizure control than even gross total resection. The seizure control rate can up to over 90%. However, as we know, supratotal are not always easy to achieve, and the follow-up data showed in this article was collected only at 3 months after surgery. The seizure control rate will further decrease over time. In the same year, another study published in Neurosurgery investigated this issue from another direction. They performed a quantitative study and found that post-operative seizure control was more likely to be achieved when the extent of resection was over 91%, or the residual tumor volume was over 19 cubic centimeters. So make a summary for this part. It can be considered that the greater the extent of resection, the better the post-operative seizure control. Moreover, the extent of resection was stratified through the comparison between pre- and post-operative MRI. So, a gross total resection is not always equal to the removal of all tumor cells. The residual tumor cells can persistently affect peritumoral microenvironment, which leads to post-operative seizures. That's why supratotal resection can achieve better seizure control. At last, the application of electrocorticography, ECG, is recommended to guide the resection of the epileptic foci. As for radiotherapy and chemotherapy, nearly all available clinical evidence show that radiotherapy has a significant effect on inhibiting GRE. And the chemotherapy, no matter PCV or temozolomide, is also effective. As for the application of ASMs, in the guidelines, we have provided some principles. First, the administration of ASMs for glioma patients should be initiated as soon as possible after a definite epileptic seizure. Second, the selection of ASMs should follow an individualized treatment plan with adequate drug dosage and duration. Third, hepatic enzyme-inducing ASMs should be avoided for patients receiving chemotherapeutic agents. And at last, LEV and VPA are recommended for the monotherapy of GRE. And if the effect was not so satisfied, they can be used together. It looks like that the ASMs should be the main force against GRE. However, there are so many problems in their management. First, is it necessary for glioma patients to use ASMs to prevent seizures after surgery? Yes, even this is still an unresolved problem. Early in 2000, AAN, American Academy of Neurology, had published a practice parameter on ASM prophylaxis. And just in last year, they united ISNO and EANO to update these guidelines. According to the updated guidelines, they recommended that for glioma patients without preoperative seizure history, ASMs should not be applied. This is a level A recommendation. For patients with preoperative seizures, there is insufficient evidence to support that ASM prophylaxis can reduce seizure risk, which is a level C recommendation. However, are these recommendations can be applied in our clinical practice? The answer is no. According to a survey study for members from ENO, nearly 30% of neurosurgeons will use ASM prophylaxis in patients without preoperative seizures. And in fact, studies in America, Japan, and Korea obtained similar results. Another issue is that is the ASM withdrawal recommended? If recommended, when is feasible? This is also a complex issue and has been controversial for a long time. Scholars have expressed different opinions about it. Some of them recommended lifelong medication, while others recommended ASM withdrawal after a certain time, 1 year, 2 or 3 years. There is no consensus. The slide shows the only prospective study in this field. However, it only suggested that for only patients with low risk of tumor progression are suitable for ASM withdrawal. Still no clear recommendation. At present, the timing of AED withdrawal mainly depends on the subjective decision of doctors in charge. So let's make a phrased conclusion. In terms of ASM management, first, whether ASM prophylaxis should be applied, we don't know. If ASM prophylaxis can be applied, whether ASM withdrawal is recommended, hard to say. And if ASM withdrawal is recommended, when is feasible, unclear. So it seems that we have done nothing in this field. The conflict between guidelines and practice is due to the lack of high-quality clinical evidence. And the following questions need to be clarified. First, is current postoperative seizure control in glioma patients satisfied enough so that there is no need for ASM prophylaxis? Let's have a look. According to our previous studies, postoperative seizure control rate in patients with low-grade gliomas is around 60 to 70%, while in those with high-grade gliomas, the number is about 80%. In 2021, we performed a study which focused on the new on-site postoperative seizures in glioma patients. We retrospectively reviewed over 300 patients without preoperative seizure history, and all patients received ASM prophylaxis after surgery for 3 months. And the result showed that among the enrolled patients without preoperative seizures, over 30% of them experienced new on-site postoperative seizures. This is hardly considered as a good control rate, less than 70%. Moreover, if the patients didn't receive ASM prophylaxis, the number will further decrease. Here we can answer the above question. Overall, postoperative seizure control in glioma patients is unsatisfied. Even in those without preoperative seizure history, the rate of new on-site postoperative seizures is still over 30%. So it's obviously that ASM prophylaxis is necessary for glioma patients, although the current evidence or guidelines do not support. So here comes the next question. What is the cause of the poor seizure control? We inferred that the reason was the lack of individualized management. For those with a high possibility of postoperative seizures, more aggressive ASM prophylaxis should be applied rather than current routine prophylaxis. Then, how to improve the individualized management of GRE? I think we need risk stratification based on precision medicine, and we should try to find risk factors, build a prediction model, and thus identify high-risk groups. In the published guidelines, we also summarized some risk factors for postoperative seizures, such as low extent of resection, extended surgical procedure, and IDH1 mutation. However, due to the lack of evidence, those factors still need further investigation. At last, I would like to introduce some of our recent work. GRE has a wide range of research fields. For instance, tumor pathology is the basis for the disease. So we can use genomics, proteomics, and metabolomics to study it. Moreover, radiomics and functional imaging technology can be also applied to investigate the relationship between seizures and imaging features. At last, as a disease based on abnormal discharge, EEG and ECOG can be also helpful. Genomics, who have some knowledge of our team may know that we have the Chinese Glioma Genome Atlas CGGA, and early in 2018, we published the first prediction model of postoperative serial outcome based on mRNA sequencing data in glioma patients. And recently, we performed a further study based on genomic data and revealed that the dysfunction of ion channel activity and immunity in glioma patients contributed to the occurrence of GRE. And moreover, we also identified some potential shared therapeutic targets for both glioma and GRE. Of course, the prediction model was also further improved. They proposed an integrated prediction model for postoperative serial occurrence with a combination of clinical and genomic data. This is also a job that no one has done before. As for imaging study, in 2015, Professor Wang Yinyan from our team published a study based on voxel-based lesion symptom mapping and found that left premotor area may be a trigger point for GRE. And in 2020, our team published 2 radiomic studies on GRE. We analyzed the image data of 130 patients and established a prediction model for postoperative GRE based on 17 radiomic features. After that, we have been committed to the improvement of the model. The current model can have better performance in both training and validation sets, and moreover, more accurate results can be obtained by combining clinical characteristics. Compared with a genomic model, the advantage of a radiomic model is that it can realize preoperative prediction, so that some intraoperative and early postoperative interventions can be applied. Moreover, we also performed some functional imaging studies on GRE and identified some functional network features were significantly different between patients with GRE and those without. However, these results still need to be further verified. As for EEG and ECOG studies, we have applied quantitative EEG analysis to glioma patients and found some quantitative EEG features, including band energy, envelope, total power, and spectral boundary, were significantly different between patients with and without GRE. Subsequently, we will try to apply other modalities such like HFO analysis, high-frequency oscillation, to EEG data of glioma patients, and try to achieve the early localization of epileptic foci. All this above are some of our attempts on investigating GRE, and I really hope I can share the details of this works as soon as possible. And as this topic was a little small, if you have any questions about this topic, please feel free to contact me by email. It has been my pleasure to give you my viewpoints about this topic. Thank you very much for your kind attention. Thank you.
Thank you, Dr. Fan. I think it's a very interesting topic. Actually, I guess there's some question from the audience. For me, I have 2 questions. The one is, do you think there are more chance for seizure attack for glioma compared with the meningioma? I mean, overall the seizure.
Okay.
Risk.
Okay. I have talked about this question for many times. In fact, as I introduced before, the epileptogenicity of tumors varies from tumor subtype and grade. And currently, there are two subtypes of tumors are considered to be most highly epileptogenic. And one is glioma, and the other is developmental tumors like DNET. You know, it nearly 100%. It has nearly 100% seizure risk. So I think only for seizure, as for seizure risk, glioma is higher than meningioma.
Okay. Okay. My second question is about the just as you said, there are different opinions about the prevention of seizure attack for the glioma patient without epilepsy. But what is your opinion or your treatment protocol for those glioma patients if they don't have any seizure attack before surgery? So after surgery, will you give them the anti-epilepsy medicine, and how long you suggest the patient to take the medicine?
Thank you very much for this good question. Both of the two are very good questions. As for this question, in our department, we routinely give ASM prophylaxis for 3 months. That's for patients without preoperative seizures. And for patients those with preoperative seizure history, we don't have sorry, I was thinking for a while. We don't have a fixed fixed term for ASM use. We generally have them AD withdraw after they were seizure free for 1 year.
Okay, 1 year. Great.
Yeah.
Okay, thank you. So even during the radiotherapy treatment period, they still can be given the anti-seizure medicine, right? There's no conflict, right?
Yes.
Radiotherapy, chemotherapy, and
Radiotherapy and the chemotherapy. Yeah.
Anti-seizure medicine. There are no.
We can apply the anti-seizure medicine.
Okay, thank you. Thank you. So, are there any Bing, do you, Dr. Takashi Kon.
Yeah,
You have,
thank you for the great talk. So very impressive and very informative. I want to ask 2 questions. So after WHO 2021, so pathological diagnosis, molecular diagnosis is changed. So other than IDH1, so there are any possible factors to affect GRE? Other molecular factors that would affect to GRE, glioma-related epilepsy?
Oh, thank you very much. Good question. As we know, since since WHO 2016 classification, molecular parameters have been introduced the classification for gliomas, and some representative molecular changes, including IDH1 mutation and Y1P19Q codylation, and EGFR amplification and GMT promoter methylation, and the third promoter mutation. However, yeah.
Okay.
We have
so
investigate. Okay, please.
Oh, go ahead.
We have been trying to investigate the association between those molecular changes or alterations with GRE, and we wanted to find some mechanisms behind the association between the molecular alterations and seizures. However, according to our studies, we only found that IDH1 was correlated closely with seizures, but other molecular changes didn't show significant association with seizures. Thank you.
Thank you. And I want to ask another question. As for anti-seizure medications, we use perampanel for glutamate inhibitor that will expected to prevent epilepsy, postoperative seizure. So how did you feel the impression of perampanel, a new anti-seizure medication?
Sorry.
We use perampanel.
My network condition is not.
Okay. Okay. Again. Sorry. Okay. We use perampanel for preventive postoperative seizure. Perampanel is studied as glutamate inhibitor, so that will expected to prevent seizure. So how did you feel the impression of perampanel if you used this drug?
I feel very sorry because we didn't use this drug in our clinical practice. So I have no idea and have no.
I don't. You know this medicine mean? I didn't know perampanel.
Perampanel, P-E-R-A-M-P-A-N-E-L. We use in Japan newly anti-epileptic drugs other than levetiracetam or lacosamide and perampanel.
I'm not sure if.
Okay. Perampanel that is expected to inhibit glutamate release, so that will help to prevent the progression of glioma cells.
Yeah, we only use LEV and VPA and lacosamide in our clinical practice.
Lacosamide, okay. Okay, thank you. Thank you.
perampanel 中文叫匹伦帕泰、魏克泰。
对，这个咱们病房还真不用。咱们一般就是左伊拉西坦和丙戊酸。
perampanel。
perampanel， 然后还有那个他说的 lacosamide， 就是拉考山。拉考山咱们就是至少还提一提。而且现在不是推的也挺用力的嘛，但是这个他说那个确实不用。
Victor Hugo Perez, do you have a question or comment? Hello, Victor. Good morning.
No question. Just a comment. Interesting lecture. Congrats, Professor Xin Fan.
Thank you.
My regards from Mexico City. Interesting lectures. Congrats.
Thank you. Thank you.
Good to have you, Victor.
Thank you.
Thank you, Dr. Xingfan. So is there any difference between different treat modality and the different location of the tumor of the GIE?
Okay. Okay, sorry, please,
I
please
mean,
repeat.
Is there any difference in the different treatment modality related to the different treatment modality, like
Different
chemotherapy
treatment
or
modality.
resection, and sometimes after radiotherapy? Is there any difference?
Okay. I know. This is this is one of the directions of our efforts, but till now, we didn't find any difference.
Okay, how about the different location of the tumor?
Yes, also including different location of the tumor.
You mean no difference?
Yeah, yes, we have tried to analyze the association between the location and the seizure occurrence and relevant surgery, and the extent of resection. We didn't find any difference. Maybe our cases is not enough.
Okay, thank you.
Okay, thank you, Professor Xu.
Okay, any more comments or questions? Anything before we close, Ben? Any thing?
Yanni, please unmute.
Are you laughing at me, Wanli? You're muted, Wanli. You're muted. You're muted. We can't hear you. Can't hear. It could be important. What can I say?
Okay.
Can't hear. There, okay, now we can
Yeah.
hear. Go ahead.
Sorry,
Go ahead.
I just got a phone call, so sorry.
Okay, go ahead. Can you repeat?
What?
Oh, I thought you had something to say. I'm sorry. I thought you had
No,
something
no,
to
no,
say.
no. That's okay.
Okay.
Yeah, I think,
Okay.
yeah, we have. So maybe we can finish right here and try to organize the next webinar after 2 weeks.
Very
Right.
good. Thank you very much, Wanli, and thank you, Benzu, for putting all this together, and Takashi for translating into Japanese. And we have our Medtion rep here that's doing the live streaming to China. We really appreciate that, and we'll see you all in 2 weeks. Thanks, everybody. Recording's off.